on dyslipidemia in Indians. Are we different? What guidelines say? Dr. Hariram, cardiologist.
Good morning. It's an honor to be speaking in front of my teachers. I'm an alumni of Osmania Medical College. I'm Dr. Hariram. I'm coming from Continental Center. So I've tried to discuss this topic in 4 headings. One is standard definition of what is dyslipidemia. Second is what are the statistics available all over the world, and what is so special about Indian statistics, and why we are so different, and what to do. So what is dyslipidemia? Dyslipidemia refers to the derangements of one or many of the lipoproteins. It can be high total cholesterol, high LDL, high triglycerides, and low levels of high density lipoproteins. It may result from overproduction or lack of clearance of lipoprotein particles or defects in the enzymes. So there are 2 causes of dyslipidemia. The primary causes, basically the genetic disorders. Secondary causes because of some metabolic diseases like diabetes, nephrotic syndrome, thyroid disorders, and drug induced. So these are the various causes of secondary dyslipidemias. Most common in all of the patterns is diabetes and hypothyroidism, alcoholism. So what are the statistics with regard to dyslipidemia in the world? Dyslipidemia is the major important cause for coronary heart disease and the leading cause of death in the United States. The World Health Organization estimates that dyslipidemia is associated with more than half of the global cases of ischemic heart disease and more than 4 million deaths per year. And a recent estimate has shown that more than 100 million Americans, that is almost more than 1/3 of all Americans, have a total cholesterol which is more than 200 milligrams. And more than 34 million adult Americans have greater than 240 milligrams, which is considered a level for starting treatment. And the total cost associated with the treatment is probably exceeding more than $400 billion. So this is an enormous problem. Coming to the Indian scenario, we are different. And this is how we are. So we have more studies from the Asian Indians who are living outside. So this is one of the study which has shown that compared to any of the compared to the US, compared to the Caucasians who are living, any of the in categories of Indians who are living there have very high incidence of coronary heart disease. The first one is the US Caucasians who are living in US. As compared to all Asian Indians, physicians, non-vegetarians, vegetarians, and spouses of them, and even the incidence rate in Delhi and Chennai are almost 5 times as compared to the Caucasians. So this is again another statistics. Wherever we live, we have a very high incidence of coronary heart disease. This is Asian Indians living in Canada, England, Singapore, and South Africa. In all the places, the CHD mortality rates are higher. So, and another estimate has shown that the prevalence of CAD has doubled to almost 4% and quadrupled to 11% in urban Indians over the last 4 decades. And this is there in 30 to 69 year age group. This is there in physicians, spouses, vegetarians, non-vegetarians, I have said previously. And unfortunately, 50% of the reported infarctions occur in Indian men under the age of 50 years. And more than 25% of them are occurring under the age of 40 years. So according to one slide from Dr. Inas Inas, we are facing a tsunami of premature heart disease, and the estimated increases in over a period of 6 years from 2010 to 2015 is anywhere from 30 to 40%. And another report from Amsterdam has said that the incidence of dyslipidemia is probably increasing by almost 27%, from 192 million existing to around 245 million, as compared to the Chinese population where it is increasing by only a modest 15%. So this problem is enormous. Why we are different? We have this is a broad hypothesis. There is a lot of factors involved. One is the rural to urban migration. There is a lot of physical inactivity. We consume a lot of calorie dense foods, high fat diet, and we have a high incidence of hypertension, dyslipidemia, metabolic syndrome, and diabetes. in the presence of high intake, high smoking. So we are not, because of these reasons, we are prone to a high incidence of coronary artery disease. So I'll be concentrating on dyslipidemia because that is a topic. So we have a pattern of abnormal lipids. We have a high lipoprotein A. We have low HDL. I'll be discussing them in detail. So we have what is called as the Indian dyslipidemic triad, that is the atherogenic dyslipidemia. We have high incidence of triglycerides, high lipoprotein A, high small LDL and low HDL, and this is responsible for our for the increased incidence of coronary artery disease. So this is a comparison of what we have as compared to the Western population. Our total cholesterols are found to be similar or lower. LDL cholesterol is similar or lower in one of the studies, but we are still prone to higher incidence of coronary artery disease. Our HDL cholesterol is lower. Our triglycerides are higher. We have high incidence, high lipoprotein A, and we have higher small dense HDL and higher dense small dense LDL. Coming to each risk factor, we have a lower total cholesterol. In one of the studies, we have found that 75% of patients with myocardial infarction had lower total cholesterol, indicating that the threshold for total cholesterol levels above which the risk increases is probably low in Indians. We cannot take the standard 200 milligrams per deciliter as the level for cutoff. We have a high triglycerides. In many of the studies, it has been shown that the Indians have a high triglyceride levels. It could be because of our diet rich in carbohydrates, and they have been shown to be associated with higher levels of small LDL, small dense LDL, which is considered to be highly atherogenic. We have a very low HDL, and according to one study, we have found that only 4% of Asian Indian men and 5% of Asian Indian women had the required optimal HDL levels. And average HDL cholesterol concentrations are low, whether they are residing in India or anywhere outside. And not only they have a low HDL, but they also have a small, dense, dysfunctional HDL particles, which are less useful in the reverse transport. And in one study, we have found that the level of HDL2B, the most protective component, is low in almost 90% of Asian Indians. We also have what is called as a high small LDL. LDL particles are divided into two patterns, A and B. Pattern B has more of small LDL particles. Pattern A has more of larger LDL particles. And the gap junctions between the endothelium is around 29 nanometers. The smaller LDL particles are easily able to diffuse through these gaps and are able to settle down in the subendothelium. And these are further oxidized, and oxidized LDL can enter the macrophages and is responsible for the plaques. So when you compare similar levels of cholesterol levels, for example, if we have larger particles, large LDL particles are less, and more of small LDL particles to equal 100 milligrams of deciliter. So as I have said, these small LDL particles are able to diffuse easily into the subendothelium and are responsible for the initiation of damage. And in a study in Asian Indians in UK, the prevalence of small dense LDL was higher as compared to the local population. This is 44% as compared to 21%. So Indians also consume a high carbohydrate diet, and this is probably responsible for the increase in incidence of small dense LDL formation. We also have a different body distribution, abnormal fat distribution. In one of the study, it has been found that the abnormal fat distribution is characterized by a high waist to hip circumference ratio, and this is responsible for the production of high levels of non-esterified fatty acids, and these are further responsible for reducing the concentration of HDL and increasing the concentration of small dense LDL. And lipoprotein A, this is lipoprotein A is spelled as lipoprotein little a, though it is made up of all the particles, but the apolipoprotein is replaced with, instead of A, it is replaced with apolipoprotein little a. This has a similarity to the plasminogen, the fibrinolytic component of the fibrinolytic system, and because of this, this increases the risk of CVD because of its prothrombotic antifibrinolytic effects because it interferes with the usual fibrinolytic effect, and also structure similarity with the normal cholesterol. It increases the atherogenesis, and it also has a pro-inflammatory properties. So lipoprotein A may be the only risk factor that promotes both plaque buildup and abnormal blood clotting, and the presence of ApoA attached to LDL makes it 10 times more dangerous than the usual LDL particle. This is one of the figure which shows a plaque which has been removed from the right coronary artery from an elderly elderly gentleman who is a vegetarian, but the only risk factor was lipoprotein A. So that indicates the importance of lipoprotein A. And more than 10 studies, in angiographic studies in India have shown that lipoprotein A is probably the most important risk factor, especially in premature coronary artery disease in patients younger than 40 years of age. So there are many other factors which I will describe briefly. Physical activity, studies have shown that Asian Indians are more physically inactive as compared to any other group. And we have what is called as a contaminated vegetarianism. We take diets which are low in omega-3 polyunsaturated fatty acids, and though we are more of vegetarians, but we use liberal amounts of saturated fats and trans fats. We deep fry our foods, and we also do overcooking. So this is also taking away all the advantages of vegetarianism. We also have genetic predisposition, which is probably the studies are going on. There are associations shown with a few of the genes like apolipoprotein B gene, apolipoprotein E3, and other genes, which are making us more prone to coronary artery disease and dyslipidemia. So what to do? We have ATP3 guidelines. This is the older 2001, which says that the LDL cholesterol should be less than 100, and less than 200 is the total cholesterol which is desirable. But are these guidelines sufficient after seeing all these things? So the total cholesterol levels are supposed to be lower in Indians because at the same level of cholesterol we are more prone. So that's probably the better number would be less than 160. LDL level of less than 160 is appropriate for the Western population, but it should be less than 100 milligrams per deciliter for Asian Indians. So we had a session in second Indo-US Health Summit where some of the guidelines were given. So according to that, the total cholesterol level should be less than 160 and the LDL cholesterol should be less than 100. Probably now it should be even lesser, seeing all the risk factors that we have, and even at lesser levels of LDL cholesterol we are more prone to develop coronary artery disease. So apart from this, what to do? These are the few guidelines that were given in second Indo-US Health Summit 2009. So lifestyle interventions are most important. Patients should be educated about the risks of cigarette smoking, physical inactivity, and they should be given education about the cardioprotective lifestyle, dietary changes, weight reduction, and use of omega-3 fatty acids. First and most important is the maintenance of the regular aerobic physical activity. We should encourage all the patients to at least 30 to 60 minutes of moderate intensity aerobic activity, preferably brisk walking, and at least 5 times a day, 5 days a week. And then increase the consumption of omega-3 fatty acids, though there are the varying reports as compared as the use of omega-3 fatty acids. One of the reports have shown that they lower the mortality. This is in as new as April 2013. Another report has shown that in May 9, 2013, another report has shown that they are probably not much useful, but still as of now, we are advocating the increased consumption of omega-3 fatty acids till the time more reports are available. We cut down on saturated fats. What are saturated fats? These fats are derived from animal products such as meat, dairy, and eggs. They are also found in coconut, palm, and palm kernel oils. And examples of foods containing high saturated fats are cream, cheese, butter, ghee. All these should be cut down, even coconut oil. Cut down on trans fats. The trans fats are found in all fried foods, French fries, and they should be cut down. So in a study by the Center for Science and Environment, it has analyzed the usually commonly used foods, especially by our children, that McDonald's Happy Meal, Haldiram's Aloo Bhujia and fried chicken, and even just one packet was found to have the more than daily requirement of the trans fats. So the lipid management, I'll not be stressing more on the dietary therapy. The statin therapy, I'll not be stretching more on the pharmacological therapy. Assess fasting lipid profile in all the patients during hospitalization and initiate lipid lowering medications before discharge according to the following schedule as given by the Indo-US guidelines. And promote daily physical activity, weight management, encourage increased consumption of omega-3 fatty acids. These are the guidelines given by the Indo-US Health Summit. So the statins are very effective in reducing the LDL cholesterol level. They should be aggressively used. Fibrates are more effective than statins in reducing the triglycerides, especially the atherogenic dyslipidemia in Asian Indians. So niacin, there is a big question mark after the 2 studies. I won't be discussing in detail. So what probably works for our Indian population is a combination of treatment with statins and fibrates, or fibrates with omega-3 polyunsaturated fatty acids. Lowering LPA, will efforts to lower LPA reduce the risk of cardiovascular disease? We don't know because we don't have the proper tools to lower it safely and effectively. We had niacin, which was reducing LPA by about 30%, but presently, after recent studies, again, there is a big question mark. So other things are like involving the media and social marketing. These are all the guidelines given by the Indo-US Summit. Then the government also should develop policies regarding reducing the CAD and the risk factors, like mandating the food labeling, including the size and calories, total fat, amount of trans fat. So concerted research effects and clinical experimental efforts need to be devoted to investigate determinants, pathogenesis and correct management of dyslipidemia in Asian Indians. And we should initiate young physicians in this subject in the undergraduate teaching curriculum and should include lectures on hyperlipidemia. Thank you.
That was a good lecture from Dr. Hariram. Any questions from the audience?
Yeah, statins are probably responsible for only a part of the problem. The problem should be dealt holistically. It should predominantly involve the lifestyle modifications first. Yes.
Lifestyle modification comes very slowly.
Yes.
And statin is one pill which can be bought by each and every population.
Yes, maybe in future guidelines we'll probably see, but I think we need larger studies, at least in our setting, to say that general use of statins in all population, irrespective of levels. Maybe the day will come.
Maybe in the tap water.
Pardon?
Maybe in the tap water.
Maybe.
In a primary prevention, you advise statins from some particular group of the people.
Yes.
Who are they? Particular set of the people, or at high risk?
No, in diabetics especially, we definitely use and anybody with a family history probably, and at least that's all. Family history of heart diseases, and especially with lipoprotein A, because as of now we don't have a proper treatment for lipoprotein A, and even lower levels of LDL cholesterol with a high LPA probably should be treated with statins aggressively, even though their levels are lower, and diabetics.
And sir, is there any practical utility of doing the LDL subtraction while treating the patient?
Yes, definitely. But unfortunately, it has not come up in a larger way, probably because of the cost involved, and presently many of the labs are not doing. That is very important to see the subfractions, especially persons who are having small LDLs, higher levels of small LDLs. They should be treated more aggressively.